Good morning and welcome to the 6th meeting of the Health, Social Care and Sport Committee in 2026. I've received no apologies for today's meeting. The first item on our agenda is for the committee to decide whether to take items 5, 6, 7 and 8 in private. Do members agree to take these items in private? Thank you. The second item on our agenda is to take further evidence on the Scottish Government's draft Climate Change Plan 2026 to 2040. The committee previously took oral evidence on the draft climate change plan at its meetings on the 13th and the 20th of January. I welcome to the committee Professor Sir Gregor Smith, Chief Medical Officer, Philip McLean, Head of NHS Facilities and Environmental Sustainability, and Wendy Rayner, Lead NHS Scotland Circular Economy Advisor, Scottish Government. And we'll move straight to questions, and Emma Harper.
Thanks, Convener. Good morning to you all. Thanks for being here today. I'm just going to open up with some questions, and I suppose down the line I'll probably come back about green theatres and propellants from inhalers and things like that, because I'm interested as the Lung Health Cross-Party Group convener. But I'm interested in what discussions are happening around emissions reduction following the government-wide Health in All Policies approach, and how closely are you involved when taking emissions reduction or net zero approaches in healthcare?
Well, first of all, thank you for the opportunity to come and give evidence on this. This is something which, as you know, I've outlined in several of my annual reports now, that I see as one of the biggest population health challenges that we currently face, not just in Scotland, but across the globe. And ensuring that we take an approach to address some of the human effects of the planetary health crisis is absolutely critical, and it's particularly important that we do that in an integrated way so that we don't miss the opportunity to also tackle those other population health challenges that I've outlined. So a balanced approach across those 4 population health challenges is really important. Now, in terms of emissions, I'm delighted that I have been able to be involved with other clinicians across the country in beginning to shape our approach across NHS Scotland to how we tackle the issue of emissions across the estate. Although much of that work involves the infrastructure of the estate, there's been an incredibly important work stream which relates to how we reduce the healthcare impacts or the care impacts of emissions as well. My starting point is this. First of all, the most harmful type of care to the environment is care that is not necessary. So if we take a much more balanced approach to prevention in the first place, and we take that as our priority, that's the very first step that we have to make sure. So making sure that we have got a national approach to improving our approach to prevention. Of course, that's not only going to help us in terms of the impacts on planetary health, but it's going to impact very clearly on human health as well. Second is identifying that healthcare that is provided that doesn't significantly improve the health of our population or those patients that receive it. OECD suggests that most healthcare systems, about 20% of the resources utilised in providing care actually don't improve health. So using a value-based approach to health and care to make sure that the kind of care that is provided is materially improving people's health is the second part that I would outline. And then of that healthcare that is provided, ensuring that we make practices and make choices that try to minimise our impact on emissions is the next step, whether that be through volatile gases, whether that be through the propellants that you've spoken about in inhalers, or whether that be looking at kind of greener healthcare pathways and alternatives to what we might think of as traditional healthcare to improve health and then help people with healthcare. As I say, I'm delighted that through the Realistic Medicine programme of work, through value-based health and care, and through my work with colleagues across the country, clinicians have been fully involved in actually identifying new ways of working that can help to improve our emissions profile in Scotland.
And you mentioned prevention, and obviously it's not just a health portfolio that looks at prevention. So last week I asked Cabinet Secretary Neil Gray about how housing can impact and improve health, for instance. So how does cross-portfolio work in terms of working together to look at what we can do for supporting the NHS for emissions reductions? But it is a cross-portfolio thing.
It absolutely has to be a cross-portfolio thing. I think everybody on this committee will be familiar with the Marmot model of health. And of course, right at the basis of that model is that probably about 80% of the contribution that we can make to improving the population's health comes from outside direct provision of healthcare. It comes from some of our socio-economic policies, it comes from education, it comes from a variety of different aspects. So health in all policies, ensuring that there's cross-portfolio working within government, the kind of mission-style government to improve health, absolutely is a critical part of the prevention strategy. And members of the committee will be very familiar with the population health framework, looking at primary prevention in particular, to see how we make sure that that approach to prevention is embedded right across not just government but actually across all sectors to improve the health of the population. That has to be the starting point, both for the benefits that that's going to have on healthcare utilisation and a sustainable healthcare system of the future, but just the very fact that we make our population healthier, more resilient, and then utilise less resource in providing care also has net impacts, beneficial impacts in terms of how we manage the planetary health crisis as well.
Okay, and just a final question. In terms of health inequalities, does the climate change plan reflect how we can tackle health inequalities? Because a lot of the challenges that we have with the population health strategy, thinking about Good Food Nation plan, all of that is under the whole climate change plan in process. So, I guess, to try and be succinct, the health equity outcomes, does the climate change plan support that?
In my view, it does. And this is the key part I want to reiterate here just now, and I apologise for going back over this territory again, but when I think about the 4 population health challenges that we face, so if we just quickly run through those, the ongoing threats which are posed by infectious disease, which are, remain a very real global threat to us. The need to improve both life expectancy, healthy life expectancy, but also close the gap in health inequalities in the country. Creating a sustainable health and care system in the face of demographic change that puts additional pressure on it, and the planetary health crisis. Those 4 elements that we have there are absolutely intertwined. If the point I was trying to make at the beginning of my evidence here today was that if we choose to concentrate too much of our efforts on only one of those streams, that will have a negative impact on the other streams. Making sure that as we approach the planetary health crisis and trying to improve the impact not only of health care on the planetary health crisis, but actually prepare for the different type of threats we're going to have in healthcare in the future due to the planetary health crisis. If we don't prepare that in a just way, if we don't make that transition, recognising that it's those who suffer the inequalities in our communities who are going to suffer most the impacts of that planetary health crisis, then we'll only compound and make worse the problem.
Okay, thanks. Thanks, Convener.
Brian Whittle.
Okay, thank you. Good morning, Professor Smith. I was really interested to hear you talk about the preventative agenda, which is something that's very close to my own heart. And much talked about in the whole time I've been in here. That's my whole. I've talked about the whole time, and yet outcomes continually begin to slide. So, really pleased to hear it's top of your agenda. What we've been doing so far hasn't worked. What's different now?
So first of all, I could talk about prevention all day because it has to be at the core of our response to create a more resilient society for the future, and actually to make sure that we're socio-economically even in the position to be able to prepare for the future as well. Our prevention agenda is one of the most important national things that we can try to do to make sure we've got a sustainable health and care system for the future. What I think has changed is a much better understanding of the need to make interventions as far upstream as possible for our population, and what type of interventions actually have a beneficial impact on that. So going back to the point that the previous committee member was asking about, ensuring that we've got an all-government, all-sector approach to prevention and making that coalition ready to act in a mission-style way, I think is one of the biggest changes that I've seen just now. The evidence tells us where we need to intervene now. I think that there's a strong evidence base that we've been able to play into the work of the Population Health Framework that tells us where we have to intervene. And what I see now and what I hear in the conversations that I have with organisations that will be charged with delivering that progress is a much greater degree of understanding and willingness to become fully involved in that agenda for the future. A good example of that would be the move from our health boards to become public health organisations. That might sound strange, but our NHS in Scotland for a long time now has concentrated very hard and very well, I think, on fixing things. Making sure that we now get upstream and that we use these institutions to promote that prevention agenda and to make sure that we're taking steps that actually act with our communities to reduce the burden of disease that we're going to see in the future, I think is a much greater priority on the agenda of all meetings that I've been involved in with these institutions certainly the 13 years I've been in government.
If I may, again, it's a conversation that I think you and I have had a few times in this. I think my issue with this is we've always known, well, we've known for a long time what would be impactful in terms of moving medicine upstream. It makes logical sense to prevent things happening in the first place. We've always talked about that politically from what we do in here. What do we need to do in here to promote and to support that kind of agenda?
Thank you for that question, because I think it's a really important one. And having the support of this committee to make sure that prevention is right at the forefront of everything that we do is really important. One of the things which I would like to see much greater emphasis on is when we think about how our ecosystem is performing and the type of metrics and measurements that we use to assess that performance, is ensuring that we've got a much greater emphasis now and in the future on some of that prevention work. I think is really, really important. Tracking exactly where our spend is through some of the proposed mechanisms such as budget tagging and so forth is another important aspect of this. And ensuring that the degree of scrutiny that all of us have placed upon the NHS in terms of its role as a body to fix ill health, but flipping that to challenge and scrutinise the NHS and other organisations that are involved, whether that be in local government, whether that be from other sources, about their contribution to that prevention agenda, and ensuring that we've got the right measurement framework to do that, I think is one of the most important things that this committee can contribute in the future.
Thank you, Kavina.
Sandesh Gohani.
Thank you. A declaration of interest as a practising NHS GP. Good morning, Sir Gregor. I have some questions, but I want to just go back before I ask the ones that I'm down for this, because you spoke about essentially giving health boards more power and greater scrutiny and budget within the community. Now, I have a lot of concern if we look at the Queen Elizabeth as a prime example. The way that they covered up and the scandal that has arisen due to contaminated water. If we look at the Chief Nursing Officer, Mrs McQueen, who had gone on to basically bribe a patient. Now, are these the type of people, is this the type of organisation, as it is, that could possibly be given more power, more money and more responsibility?
I don't think that I said in my evidence at all this morning anything about giving health boards more power at all. I don't think that that has been any part of the conversation that I've had for. What I have said, and just to recount so that there's no mistake in any of that, is I have said that what I see is that NHS organisations are invested and are contributing in a much greater way to the prevention agenda. And they realise that the benefits of that for the populations that they serve will actually reduce the burden of health and therefore produce a much more sustainable model of care that they're able to provide in the future. So what I see is that health boards are accepting their role as public health organisations for the promotion of health and well-being alongside the delivery of health care which will remedy what they can in terms of the problems that people present with in the hospital. But I want to be very clear, at no point in the evidence that I have given today have I said that I think that health boards should be given any more power.
Well, if we consider a health board being given the ability to do a lot more in the community, presumably health boards would be given more money to be able to fulfil the agenda that you're speaking about. Does that not equate essentially to more power?
Again, I disagree with your assertion there. And I think that what we are talking about is health board using the resources that they have in a much more focused and perhaps people would say in a much more precise way to try to improve the health of the communities that they serve through the use of data to identify exactly what the needs of those communities are and then to pivot and ensure that the interventions that they are supporting within the community through their own work, through partnership with local government and health and social care, is that supports the promotion of more cohesive, healthier communities.
So if we take that, and obviously with the inverse care law, we can look at a group in Drumchapel. It serves a community which needs as much intervention and help as we could possibly give. It serves a community which has a lot of asylum seekers within it. And if, let's stay away from the politics of that, but essentially these are people who have need triple appointments because of what they're coming in with, the fact that they don't speak English. And the healthcare system they've come from means that they do need to get triple appointments to have the time for the doctors to deal with it. The facilities aren't acceptable. They cannot expand. They're old. Essentially, they've been left to rot, the GPs and the doctors in the Drumchapel Health Centre. So would your idea then be to use resources from the health board to tackle a problem like that?
So, in my view, one of the most important aspects of the prevention agenda just now is to identify through the precision use of data exactly what the needs are of the different communities that are served, and then the services should be focused on how you best serve those. So, if you like, through the process of whether it be budget tagging or community planning, identifying exactly how those resources that are given can be used in the best way to improve the health of that specific population. And you're right, our populations, our communities are not homogenous at all. And in my view, and as an independent advisor to government, I have advocated for a long time now about the greater use of proportionate universalism in terms of how resources are identified and then used within a healthcare system. We've seen that used effectively most recently with the production of the GP directed enhanced service on prevention of cardiovascular disease, whereby those GP practices that were serving communities that were socioeconomically more disadvantaged have been given disproportionately more funding to allow us to try to reach those communities much better than we've been able to do in the past. And we have to have new techniques of being able to engage with the communities that we have, because all of us would recognise that one of the biggest barriers that we've had in Scotland to improving health is actually engaging with some of our communities in a meaningful way that actually starts to improve health. Wendy and Philip are here today with me as well, and they will be able to say a little bit about the estate and how that's developing across the country. But I think that the clever use of some of the capital funding that is available to make sure that when we are developing the NHS estate from which services are delivered, we do that in a way that actually serves the community needs much better. And that might not be in a purely healthcare facility, as you know. That might be about making the best use of a building for the community purposes, bringing in other services, but with the view of making sure that the estate that we do have has a net zero effect in terms of its carbon emissions. Now, I invite Wendy or Philip just to say in more that they might want to say about the estate.
Oh, sorry, questions about the estate. Certainly, that's the very next question. But on the point that you have made, we have seen the GP funding going up in Bearsden because it's a slightly older population. So, we've got a very wealthy area and a deprived area, both having a bit more funding, but the money really does need to go to the deprived area. So, on the actual estate, what is your estimated cost to bring the NHS estate up to scratch within the plan and make it net zero?
Philip, do you want to take that?
Yes, I'm happy to answer that question. So we have a low confidence estimate of £700 million capital. Now, we don't have a great deal of confidence in the methodology that's been used to develop that estimate because it's based on high-level net zero roadmaps, which were prepared for health boards a number of years ago. To improve our estimate, we are supporting health boards to prepare detailed site-level decarbonisation plans. While there are 900 sites across the NHS estate in Scotland, only 20 of them account for over 60% of heat and power emissions, and these are our priority sites. So, for example, the Forster Hill site in Aberdeen produces 13% of heat and power emissions in the NHS, and a site decarbonisation plan is being prepared for that site currently. That estimate that I provided also doesn't take into account the effect on the revenue budget of the measures that are being planned. So many of the measures that we are planning will actually cost less to do because they will result in savings to the revenue budget. That includes measures such as the installation of LED lights and upgrades to building management systems, both of which have short periods for the return on investment, meaning that within a few years it's actually cheaper to do the investment to make that change than it would have been not to make that change.
Can I just ask, on the point about changing light bulbs, how much does it cost to change an NHS light bulb?
So I'm afraid I can't provide you that level of detail. However, moving from fluorescent tubes to LED lighting isn't, in a hospital environment isn't straightforward. Of course, there is rewiring that needs to be taken. It's not simply in light fittings that need to be changed. It's not simply the case of changing a light bulb. I would also highlight that in a healthcare environment, there are design requirements for lighting that need to be taken into account, and things that perhaps people wouldn't have thought of, such as the position. For example, in a hospital corridor, you can't have lighting running up the middle of the corridor because patients are pushed around in trolleys, on beds, and you don't want them staring up into the lights. So it's not quite as straightforward as switching one light bulb over for another.
So it was a question. So you were still speaking about other things, sorry.
Oh, yeah, sorry. So I was talking about the capital cost. The other thing that it doesn't take into account is how much of that cost will need to be paid for by the public sector. Part of our strategy is for health boards to connect large hospitals into district heat networks. And of course, the district heat networks will be paid for by the developers of those heat networks. And another part of the strategy, which is related to that, is to seek opportunities for health boards to secure power purchase agreements. These are agreements with generators of renewable electricity, whereby the electricity is supplied direct to the NHS estate. Of course, in that scenario, the health board pays for the cost of the development through its electricity bills, but the capital costs are funded by the developer of the solar farm. So we are working to improve that estimate and develop the financial model that will give us a better understanding of the true financial effects of decarbonisation on the NHS.
And my final question is about the fact that we have an estimated £1.5 billion maintenance backlog. Now, do you feel that that needs to be addressed urgently and buildings need to be maintained and brought up to standard? Again, I go back to Drumchapel Health Centre, where the GPs were told they couldn't create another room because it wouldn't meet current health standards, but it's okay for them to be in their current rooms, which do not meet health standards currently because it was historic.
So I think, first of all, for the overall context, that patient safety is our #1 priority. This financial year, the Scottish Government is providing £114 million of additional investment for priority maintenance and equipment replacement in the NHS, and that's on top of Health Board's delegated capital budgets of £156 million. So that's the largest increase that we've seen for maintenance and equipment that I'm aware of, certainly.
It's been cut, right?
No, there haven't previously been cuts to equipment maintenance. To maintenance and equipment replacement.
Budget.
The delegated capital budget has stayed roughly around the same level for a number of years, but we're now that's starting to increase. Of course, the capital budget funds more than maintenance and equipment replacement. It also funds new developments and things such as the ambulance replacement programme, and there's also technical elements in there, such as health research and budget cover for leases. On the question about the relationship between decarbonisation and backlog maintenance, I think it's important to remember that, or to appreciate that these are not separate categories. One of the main risks in the NHS estate is the continued use of steam heating systems. These are expensive, inefficient, and they're difficult to maintain. Moving to more modern heating systems that use medium temperature hot water is an important part of addressing that backlog maintenance. It's also a very important step in preparing a hospital to use renewable heating, because while renewable heating systems can produce steam, it's more expensive to do so, and they operate much more efficiently with lower water temperatures. So these two things, decarbonisation and modernising the estate, are actually connected.
Thank you.
Gillian Mackay.
Convener, just to follow up on the questioning that Sandesh Kulhani just did, one of the things we don't talk about is electrical waste within hospitals. There are, by the nature of how healthcare is delivered now, a number of big machines doing lots of work across the hospitals, but these are often come to the end of their life, either because of patient safety issues, they're no longer safe to keep doing their job, but there's also an element of the companies that make them, software updates, and them then becoming redundant because of those updates. So what work is being done to reduce that level of electronic waste across the NHS, and how are we making sure that anything that does have to go for patient safety reasons or anything else is being recycled or repurposed to make sure that we're not putting loads of stuff into landfill?
Thank you. In terms of waste management, there is a National Waste Management Steering Group which oversees all the activities of all the health boards. They coordinate their activities via the Waste Management Action Plan. There is also a national framework contract in place for waste management services, of which electrical goods is one of the components of that. In respect to reducing the amount of electrical waste that's generated, a large part of that falls within the Circular Economy Work programme. and we're working very closely with suppliers to try and change the format, I would guess, of those contracts, where we're looking more at access contracts or the possibility of leasing, allowing that equipment to be upgraded during its time on our sites.
That's really useful, thank you. I want to turn to transport and how people get to and from the NHS estate. We know that there's a great number of vehicles now that are electric vehicles within the fleet that allows staff to go from site to site. But for staff getting to hospitals and arriving at their work, what are we doing to make sure that people have the ability to make alternative choices to get to health and social care settings and enable a shift to low carbon travel, especially in remote and rural areas? And I'm sure folk around the table will be very aware of some of the parking issues around hospitals across the country, and the fact that we've discussed at this committee before the letters that go out in many health boards saying arrive 10 minutes before if you're arriving by car because of the issues with parking.
Philip, you've been involved in quite a bit of work with this.
Yes, thank you for the question. So I think it's an area where further work is without a doubt required. There has been some progress by health boards where, for example, to assist staff in taking more sustainable travel options, they've put in place things like cycle to work schemes and also discounted bus travel. They've made arrangements with local bus companies. There have also been improvements on NHS sites to the infrastructure for active travel. So, for example, secure cycle lockers being installed. However, NHS sites are ultimately they're either a destination for a journey or they are a starting point, and therefore this is an area where collaboration with local authorities, regional transport partnerships and transport companies is absolutely essential, and that collaboration is happening, but I think it's fair to say there is still more to be done. At a national level, NHS Scotland Assure engages with all 7 regional transport partnerships, and at a local level, health boards also meet with their local regional transport partnerships. You mentioned the example of patient letters, and that is something that was raised, I think, last week at the National Travel and Fleet meeting by NHS Scotland Assure, and the transport leads will be taking a look to see what their own particular health board says in their appointment letters, because undoubtedly practice varies across the country. So it is an area where work is being done on the NHS side. There's more to be done there, and collaboration with local authorities and others is absolutely essential.
Great, thanks, Convener.
Emma Harper.
Thanks, Conveners. Just a bit of a supplementary to that. NHS Dumfries and Galloway advised people to arrive 15 minutes early for appointments so they can find a parking space. And when I wrote to them to say, can you do some information about active travel and getting buses and cycle routes, they actually came back very positively and said they are working to improve measures like engaging with public transport and community transport initiatives as well. I also was interested, when I worked in Los Angeles, we had a carpool scheme where you got points and points made prizes if you shared a car or rode your bike or even walked. And so is that something we should be pursuing more of here? Is like we carpool initiatives in order to encourage car sharing so that the car parks aren't full?
There is a good car sharing initiative that has been widely publicised across Scotland. These guys might know just a little bit more about the detail of it, but I know that already that's in place and has led to quite a significant reduction. And if you look at overall business miles as well, in terms of the NHS usage, that's fallen substantially, as has the carbon emissions that are associated with that as well. Now, as I say, perhaps these colleagues will know some of the detail in terms of the actual the figures round about that, but I know that it's already in place.
On the point about business mileage, so in 24-25, it was a total distance of 45 million miles in business mileage claims were made. That's for car travel. The year before, oh no, my apologies, my figures are the wrong way around. In 24-25, it was 42 million miles, and the year before it was 45 million miles. So that's a decrease of 3 million miles in business mileage claims. On car sharing, absolutely, it is something that would assist both in terms of reducing emissions, and it also provides a way for staff to reduce their travel expenses. It is promoted across the NHS, but it's principally marketed on the basis of it's a way to reduce cost and reduce emissions. I'm told that while the car sharing has been promoted, it has been difficult over the last few years since it was prohibited during the COVID-19 pandemic. There was definitely a fall off, a drop off then, and it's now starting to recover.
Okay, thanks.
Little.
Thank you. I'm going to sneak in a wee shot on that previous, if I could. One of the things that strikes me is that we always hear about this: arrive 10-15 minutes earlier so you can get a car parking space, etc. Do you think that we're just completely unrealistic in the expectation when we're delivering healthcare, especially at hospital? Like Glasgow decided that they understood that in the future there'll be much more active travel, there'll be much more people arriving by public transport, and that's just unrealistic given the nature of what the hospitals deliver.
I want to go back to the point I made earlier on in my evidence, Brian, if I may, and that's for all of our healthcare systems to be very aware of the communities that they're serving, to be aware of them in terms of the geography of that local community, but also how that local community works, the patterns of travel, the challenges that those communities face as well. And when we're planning services, I think it's really important that we factor all that in. There is no doubt in my mind that one of the most important aspects of reform of the healthcare system now and in the future has to be the greater proportion of care taking place within those communities itself, and to be using the hospital not as the default for care, but as the way of escalating care and, really importantly, de-escalating care thereafter when it's necessary as well. So moving our thought processes whereby people see the hospital as the kind of cathedral of care within our system, and recognising the huge contribution, the foundation that community services provide has to be the future. And some of that might be examining the way that we provide services in the future and what specialties can take the care that they provide traditionally within a hospital outpatient setting much more close to those communities as well. We're already starting to see that shaping within our communities just now, and I want to see more of that in the future. So ensuring that we've got the infrastructure within a community setting to enable that to happen, to prevent those journeys to those huge cathedrals, the hospitals themselves, and making sure that we're providing care in other places closer to where people come from. That has to be, as I say, one of the most important and critical outcomes of future service reform.
On to my substantive, what I'm supposed to be talking about. And I don't disagree with you, but I think how you get to that position is, I think, where the issue is. Can I? I'm going to, the theme I'm going to talk about sort of goods and services, specifically procurement. And I've got a big bugbear around food procurement, food waste. The last time I looked, I don't know if it's still the case, but last time I looked, the food that was being, served at the Queen Elizabeth was prepared in Cardiff and driven up the M6 every day, and 55% of it was thrown out. And I know that is similar to the Edinburgh. That has to stop. So how are we tackling that particular issue?
I'm certainly aware that there's a number of different work streams in relation to procurement, and food, of course, sits right at the heart of that. And that's split into, I think it's 9 different subject headings for those procurement. The majority of which have actually been shown. The majority of food procurement and it actually takes place from local suppliers. Prepared meals, pre-prepared meals, or delivered meals are slightly different in terms of there's no Scottish supplier that's able to do that to the specification which is necessary just now. But as I say, I think that there's been there is good evidence that actually those procurement lines are done as local as possible. Now that's good for the environment because there's no travel costs, but it just makes sense from the point of view of supporting local communities and supporting supporting economic development in those communities, as well as that's done as close to the hospitals as possible. Again, my colleagues might want to say more on this, but it's one of the things that I've seen come through the oversight board, which I've been reassured by.
Yes, so it's correct. There are 9 NHS National Procurement Food contracts in place. Out of 8 of those framework contracts, the suppliers are all based in Scotland. As Gregor says, one supplier, and that's for the direct meal service framework, is based in England. That framework provides special diets and texture modified food, and there isn't a supplier in Scotland that can provide that service. The amount of food that's produced in Scotland varies from framework to framework. 100% of milk and dairy products, 80% of butcher meat and meat sundries, and 70% of potatoes and veg are produced in Scotland. In addition, on the direct meal service contract, 20% of the food is produced in Scotland, although the supplier is based in England. Of course, food waste continues to be an issue within NHS hospitals. There has been some progress. Zero Waste Scotland assessed 14 health boards in 2023, and it found that all of them had reduced their food wastage compared to the baseline year, which varied for each health board, but it was in the period 2015 to 17. And Zero Waste Scotland assessed that 6 of them had reduced their food wastage by more than 33%. But this continues to be an area where there is work to make improvements. I think there are a variety of reasons for food wastage in hospitals. Some of that can be due to the quality of the food. However, unserved meals plays a part. So we see examples of over-ordering by wards on a just-in-case basis. And one of the actions which has resulted in a reduction in food waste is when electronic bedside ordering is introduced. Those health boards that have brought that in have seen their food waste go down. But that's unfortunately not in place everywhere yet.
To what it kind of leads to, or points to what we were talking about before, Professor Smith, around the prevention agenda. Surely it would be obvious that the highest quality food we can possibly serve would be to the benefit of the recuperation of patients. I mean, the last time I looked at that, which is not that long ago, as I said, 55% of food being thrown out because people weren't eating it is is a problem. I think the idea that we're building hospitals without kitchens. Surely that's a false economy. The best meals are the ones that are prepared fresh on site. So is there any consideration given to how and where we produce food and the quality of food that we deliver?
I'm certainly not involved in those discussions. That's not my area of expertise or specialty. As I say, my colleagues may want to come in if they are aware of any work that's done in that. But I think we need to remember that the provision of nutrition in hospital is overseen by experts in that field, by nutritionists, to make sure that the dietary requirements of each individual patient are assessed when that's necessary, and whether that's changes in the texture and type of food, or whether that's looking at how you establish a proper protein or overall calorie intake for the particular health needs of those patients is absolutely key in this. It's why we have healthcare nutritionists right across the NHS in Scotland and providing the work that they do. But I'm not aware from any involvement of specific work in relation to the infrastructure in terms of kitchens. But as I say, I'll pass to my colleagues in case they're aware of anything.
There is a national catering strategy, but you're absolutely correct that different models of food production have developed in different parts of the country. So we see a variety. We see cook-freeze models, cook-chill models, and also kitchens hospitals with on-site production. And I think as part of a review of the national catering strategy, there needs to be an assessment or analysis of what the best model is for the production of NHS food. I think you make very good points around the need for on-site kitchens, and that's something that has to be considered as part of a more cohesive and unified approach, recognising that geography varies across the country, and it's possible that the same model for production will not fit each area, and that's something that does need to be taken into account. On the question around the quality of food, there is a specification for food in hospitals. That was last issued in 2016. It's been reviewed, and there is a draft, a new draft version of that, which is actually intended to be published very soon. That's NHS Assure Scotland that's led the production of that, working with dietitians, Public Health Scotland, and catering leads from the health boards. And that specification sets out essentially the standards and advice on how to prepare meals for hospital catering, develop menus, and it takes into account the different needs of the patient population across NHS Scotland.
For me, there's an added advantage actually of making sure that in a healthcare facility we've got good kitchens as well. It's not just about the food preparation and what that does for people, but actually the kitchen's an important place, and learning life skills around the kitchen is really important for our communities as well. There's some fascinating work led by David Eisenberg, amongst other people from Harvard University, looking at the role of community kitchens and how they can be used to improve health. And really what that relies upon is those kind of anchor institutions, those community facilities that you do have, having well-equipped kitchens whereby you can actually begin to teach people about food preparation, about the coming together and the connection that people get over eating food, and equip them with life skills that allow them to then go away and have a healthier approach in the behaviours that they have in life as well. So, we've got to sometimes look beyond the immediately practical. what does the kitchen provide in terms of in the hospital? Actually, when you start to think about that kitchen as a place of improving health as well, I think there's an added benefit that actually we've yet to fully explore and utilise across our estate as well. And that's one thing that I would suggest that we should be looking at in the future.
Just finally, if I could, it was interesting to say about nutrition. Nutrition's one thing, but it has to be edible. If there's 55% of it being thrown out, I'm saying they may have the nutritional value, but maybe unedible. But the final question I've got then, to your point, Mr McLean, around different models across the country. Do you think there's a problem here, and you've got 14 different health boards who can do things 14 different ways, and 14 different health boards that can say no to a question rather than have a more universal approach? There's a difficulty in delivering a universal approach to this.
So it's a very interesting question. I think absolutely, and that is one of the factors that leads to variation at a local level. Sometimes that variation is a good thing. It takes account of local needs and also the resources that are available in that particular area, but it can act as a barrier to having a standard specification or a common approach. So there are always costs and benefits to these different ways of service provision.
Emma Harper.
Thanks, Convener. Thank you, Convener. It's just a supplementary, but it's back to the cross-portfolio working. The Natural Environment Bill was passed just last week, and it's got provisions in it about increasing the use of venison in hospitals and schools and workplaces, so public sector settings. And this is something that, you know, if we're going to promote venison in a sustainable, healthy, locally sourced way, we know we have an abundance of it. How is the practice of communicating this kind of action so that one bill that passes, yeah, we need to do more venison and get that into hospitals, how is that then communicated and disseminated in terms of information to different health boards? I see Wendy leaning forward.
Would you like me to try and answer? I'm afraid I don't have all the details, but the lead procurer for food across Scotland that works for national procurement, I had a conversation with her only recently, and she was talking to me about the opportunities for adding venison in. Now, she meets with the expert catering group frequently, and she corresponds with all the health boards, enabling these products to be on contract, which then is supported by the boards being able to pull those products off contract, and with the use of standardised recipes and menus throughout Scotland, then venison can be added.
Because we know that there's a school in Lockerbie where one of the teachers brings venison in and has the young people make burgers, for instance. So, and it's not just about steaks, it's burgers, meatballs and sausages. So it's about, I guess, changing our attitude towards venison because it is a good source of protein.
I'm going to come in just on food generally here just now, because I think all of us realise that in order that we ensure that for the future we have food security, we've got to make sure that we are educating and diversifying the behaviours of our population as much as possible. Now, I think there's a general acceptance there's 60% of global calories come from 4 crops. That for me is something that needs to be addressed at a global level, because those 4 crops, rice, maize, wheat and soya, are produced only in a small number of countries. And as we see global changes to the climate and the impacts of those, food security has the potential to become a real problem. So diversification of the food that we eat and changing attitudes to agriculture, I think, as well, so that we are not solely producing agriculture to feed the animals that we then choose to eat as well. All important parts of how we make sure that we have better food security for the future. So I would be very much in favour of actually how we begin to at a very young age, and I think this relies on kind of people being educated in a much more systematic way about food and nutrition and about health in general through school curriculum for the future is, I think, something that would be beneficial for us.
Sounds like Dr. Stuart Gillespie and ultra-high processed foods and things that I'm interested in for another day. David Thornton.
Thank you, Convener. Good morning to witnesses. To what extent are health boards addressing the need to reduce the use of single-use plastics and PPE? And what are you doing to promote and facilitate any cultural change and education required, both clinical and in procurement practices?
It's quite a significant amount of work in this, and my colleagues will be able to say quite a bit about it. And Wendy, I don't know whether you want to start.
Yes, absolutely. And this is an area very close to my heart. So plastics is a key material stream for us, and one in which we feel should be valued. And that is particularly pertinent because the NHS is in possession of very high-quality polymers in the products that we buy. A large percent of medical devices that we purchase are single-use. We're also aware that a large number of those contain or are comprised of relatively large quantities of plastic. In addition to the environmental sustainability impacts associated with raw material extraction and manufacturing, plastic waste has a significant impact, and this will actually add to future cost pressures via increased taxation from the emissions trading scheme, which is obviously on the horizon. It's therefore important that we address plastic waste and value it as a material stream. The Scottish Government and NHS Scotland have undertaken a number of pieces of work focusing on plastics, including work started over 7 years ago with Zero Waste Scotland supporting the extraction and processing of plastics from our treated clinical waste stream, creating high-quality recycled polymers suitable for use in future manufacturing. A position statement on plastics, which went a formal consultation managed by National Procurement, was undertaken about 18 months ago. A trial of source-segregated high-value polymers from clinical settings was undertaken last year and was deemed to be successful, such that it was then included within that national contract, that national framework for waste management services. Work as part of a larger circular economy data project, working with suppliers to identify the type of plastics as well as other materials in products. And we are linking this data to procurement system data to support future segregation and also demand modelling. This will support the waste and the resources industry to put in place plastic collections and also increase the recovery of high-quality grade plastics in the future. Finally, working at UK level, we have co-commissioned a project bringing together expertise to assess opportunities and requirements to move away from single-use items where appropriate, ensuring at all times that patient safety and the quality of care comes first, and that is compatible with resilient, sustainable and cost-effective health care. Earlier on, there was a mention of our Green Theatres programme, which is now increased to be called Green Healthcare Scotland, covering a number of different areas, not just theatres. And they've been involved in a number of pilots and projects looking at reducing our reliance on single-use plastics, including some PPE items, and also working with clinicians to embed those more sustainable practices. One trial, for example, looked at removing single-use textiles, which were used in an operating theatre on a trial basis, and we employed a company to provide textiles as a service, as an alternative, which was successful. We've now employed a project manager to look at this further, to look at the opportunities to implement this across Scotland.
Thank you for that. In addition to the Green Theatre programme, which you touched on, what specialities are being considered for action by a Centre for Sustainable Delivery? And really importantly, how are you engaging with clinicians to be innovative and reduce emissions? And what challenges are facing you in doing that?
Yeah, I mean, there's quite a significant amount of work that's underway here. And first of all, I want to recognise the work of what was the Green Theatres programme, because I think when you look at what they have achieved in Scotland and the international prominence that that programme of work has had, started. The thing I love about the Green Theatre programme was it came from a group of clinicians who were incredibly invested in making the changes at a local level, and then were able to spread that across the country in practice through the support of Centre for Sustainable Delivery as well. I mean, I think that was one of the key characteristics of this, is that this was change that had been identified at a local level, and that was then kind of spread about. And what we're seeing since then is that good news story that they've created, the enthusiasm that came from particularly the clinicians who were leading that, has attracted more and more specialties to want to be involved. Renal, for example, is a very intense area of resource utilisation because of the very nature of the type of medicine and care that people get. And it is now established that there are ways of trying to make that process much more efficient. And again, it's been led very much by clinicians on the ground. And so what we've seen now is that National Green Theatres programme expand into a green healthcare programme, where we're beginning to bring those other specialties into the fold. And I would anticipate, certainly from the kind of conversations that I've been involved in and the people that I see, the eagerness, the enthusiasm that is there within those specialties, that we'll begin to see some of the same successes that we've seen through the Green Theatres programme actually broaden out into these other specialties as well. Now, I think it's not fair just to single out certain specialties, because it's much more broad-based than that. And in the conversations that I have, I am constantly pleased and reassured by the breadth of specialties and geographies where people come to me and say, can you come and see this? I think we're doing something here that's important. And as I say, it starts at a local level, and with a bit of success and some encouragement, they begin to make an impact. And those small-scale projects, we then begin to seed now, whether it's general practice or whether renal medicine, whether it's... We know that about 20% of the emissions that the NHS contributes comes from prescribing and from medicines and so forth. So taking much more proactive approaches to the way that we use these substances not only helps the resources that we have in terms of this environmental impact on emissions, but also it's a much more sustainable form of medicine as well in terms of the costs incurred, and it's less likely to be harmful to the environment from a biodiversity perspective as well, because we've even had groups that are examining exactly the impacts of what that medicines that are perhaps disposed of inappropriately, or the byproducts of consuming those medicines have on local waterways and so forth as well. So it's a full ecosystem approach.
Thank you. No further questions?
Gillian Mackay.
Thanks, Convener. One of the things we've talked about for a very long time is electronic prescribing, and it's one of the most basic ways to save something as simple as paper within the NHS, as well as time and all those sorts of things. And I think that's just one little thing in amongst a whole load of other things that could be progressing more quickly. What are the barriers to us doing some of these simple things, like electronic prescribing, like sustainable medicine disposal, like moving to better, greener ways of giving people their medicines, blister packs, things like that? Is it resource? Is it expertise? Is it things needing to be done better globally? Is it a bit of everything?
Oh, it's a really good question, and I know my colleagues will want to come in on this as well. I'll start by giving off my views as just now. So I think electronic prescribing is really important in all of this, but we've got to put it in context, haven't we? Because although it's going to make a contribution, it's not going to make as big a contribution as some of the other things that we can do in relation to medicines. So just making sure that we are much more careful in the way that we prescribe medicines, continue medicines, review medicines, for me is the biggest prize here. And so making sure, using those Scottish prescribing guidelines that have been produced around about polypharmacy, respiratory medicine, and use of medicines like benzodiazepines and so forth, is one of the most important starting points for this. Because a medicine that's prescribed and continued but actually isn't improving things, or isn't having its intended purpose, or even worse, is maybe having harmful effects, is the worst type of medicine for the environment, because it has that knock-on effect. So, value-based health and care. making sure that we are taking that approach in the way that we are considering and sharing the decisions with people about their medicines, so that we're properly addressing their preferences for their care, is for me the absolute starting point. And yes, I agree that electronic prescribing can help in all of this as well, and making sure that that medicines management, that stewardship is optimised as well, will also help. But for me, the starting point is making sure that the medicine prescribing is as good as it can be.
So I think I was using the electronic prescribing as sort of quite a basic thing that we haven't achieved yet. So where is that blockage in your mind? Is it money to do these things? Is it a series of prioritisation to get the bigger things over the line rather than the smaller things? Well, cumulative impact.
Again, I'll pass to my colleagues, but what I see is a very crowded landscape here for investment in digital technologies just now, and ensuring that we've actually prioritised that so that we have the biggest impact that digital can produce, whilst making sure that the technical solutions that are there, and we should always remember as well that the technical solutions digitally are only part of the problem. Is making sure that you get proper adoption of those and understanding of how they're used properly, safely, efficiently as well. That all needs to come in hand as well. But I think this is so much about both the technical solutions and also the prioritisation. These guys might want to say a bit more.
I think in general, one of the things that we're trying to do, certainly when it comes to sustainability, is to bridge that gap between for example, the publication of guidance or running a successful pilot project to actual implementation. Sometimes the change that we're looking for actually involves behaviour change, and there is more support that's required from that, and we need to treat these, or we are treating these projects in that way. So we're putting in place support for health boards so that they are able to actually implement the changes that have been piloted and reap the benefits of those. I can't really speak about any particular issue with digital prescribing. I appreciate you're using that as an example. But one aspect in sustainability in general is that we are bringing together different services and recognising the dependencies that they have on each other. With Green Theatres, one of the, I think, great successes, and it's one of the less obvious successes, is that it's increased the communication and collaboration between theatre teams and between those teams that are responsible for running decontamination services. These are the services which sterilise surgical instruments. And they now have a better understanding actually of what each other require. There's fewer assumptions, and they can also. We also see examples such as a lean trays project, which is something that is very much led by theatre teams, but has great benefits, not just environmental and financial benefits, but also has great benefits for decontamination services. So for me, it is about resourcing our projects properly, taking a planning out implementation and bringing together the services which are required, which need to be involved in order to make that change successfully.
I can talk a little bit about pharmacy waste, but not about electric prescribing, I'm afraid.
Thanks, Convener.
Emma Harper.
Thanks, Convener. I'm really enjoying this morning because there's a lot going on in the NHS, and as a former theatre nurse, I'm really keen on hearing about the changes that are in the operating theatres. I'm also, as I mentioned earlier, the Lung Health Cross-Party Group convener, and we've had evidence sessions about low global warming potential propellants in inhalers, which I mentioned earlier, and I'm a wee bit worried that blanket switching will actually put people in danger when we've got a transition of low global warming potential inhalers for the multi-dose inhalers, the relievers. And I notice you're nodding already. So I guess my concern is we need to make sure that we've got the right inhaler for the right person and we check their technique rather than just blanket switching. And we need to make sure that we do it in a way that helps transition and helps make sure people don't end up having asthma events and then ended up with admissions and all of that as well. And some of the dry powder inhalers might have low or no emissions, but they're full of bits of plastic that can't be recycled very well, whereas the current salbutamol, for instance, has got bits of plastic that can be recycled. So it's complicated. But my concern is really, how do we make that transition and keep patients safe?
So I'll maybe speak a little bit just now then about the kind of clinical aspects of this, because I think they're really, really important. And I'll start off by trying to answer your question around about respiratory care, and then we'll maybe go on to some of the Green Teeters work, if I can, after that. So one of the early points of data that really attracted me towards focusing work in relation to our inhaler usage in Scotland was actually when you begin to look at international data, and both in terms of utilisation of particular devices and health outcomes. Comparing Scotland with demographically similar countries, particularly across Scandinavia, there was certainly evidence of much greater usage of short-acting beta-2 therapy in inhalers, which for those on the committee who aren't familiar with those, are generally what we call the reliever inhalers. And in Scotland, there seemed to be a disproportionate use of those in particular compared to the preventer inhalers, which are the absolute bedrock and keystone of actually how you make sure you've got good asthma care over a long time. And that high usage of short-acting beta-2 agonists in particular was leading to significant increases in the number of emissions that we were having, because people were going through so many more inhalers because they weren't actually using the preventer inhalers as well. Now, work led around the country, we've seen it in Glasgow and so forth, gives us a better understanding of actually what was happening there just now. Now, I don't think this is all just about switching inhalers. I don't think this is simply about switching from some of the gas propellant inhalers to the dry powder inhalers. This is about making sure that we were optimising the care of patients. So the 2024 BTS guidelines, which come out and start to kind of show a slightly different approach in terms of modifying drugs usage, actually take us down a slightly different route in terms of how we use those inhalers to kind of improve asthma care. So this is about a holistic approach with a patient to see exactly what works for them for their stage of asthma and for their current experience of asthma. And that's what's been certainly advocated through the Scottish Prescribing Guidelines on respiratory care. This is not just about blanket switching over to dry powder inhalers. This is about optimising the care of patients. And the side benefit of that is we should see a benefit on emissions as well. And I think that's a really important point to underline in all of this. And we've seen emissions fall. And I think that's been quite striking. And the data I've got suggests that there's been an 18% fall in emissions, even from 22-23 to 24-25, as a result of some of the work that's been going on there. So, as I say, I think that's all benefit. Now, to the side of that as well, we've got to recognise that other, again, medicines have a harmful effect on the environment that we use, and none more so perhaps than the volatile anaesthetic gases that you would be used to when you were working in the theatres. And, there's, again, been extensive work in Scotland to look at actually how we make the best use of those gases when they're appropriate to do so, but actually for the ones that are most harmful, such as desflurane, we really kind of begin to kind of stop their use in Scotland, and through approaches in national procurement and engagement with clinical teams, we've seen that the whole approach to how those volatile gases are used. Likewise, we need to examine the broader use of gases across our estate, like nitrous oxide and, or Entanox, that's often used as a kind of pain-modifying therapy, is making sure that we are making best use of, again, the infrastructure that we have that sits around about that, to reduce the amount of leakage that we've had across the system, to make sure that it's used and used appropriately. All has begun to show us that we've greatly reduced the usage of those gases as well. So side by side with some of the equipment that we're seeing used in a completely different way in theatres, what we're seeing is that the medicines that support theatres and support care across our hospitals are being used in a different way as well, and I'm really encouraged by that. And Scotland, I think it's fair to say, certainly from the community of people that I'm involved with across Europe, is seen as a leader here. I had the pleasure of signing a memorandum of understanding with the regional government in Galicia as in the last couple of years, as we kind of choose to work together on these type of approaches to make sure that we've got the kind of sustainable care embedded in our healthcare systems.
Is there still a place for nitrous oxide in maternity services and ambulances?
Absolutely.
And emergency departments?
So absolutely. This is not about removing that as an option, but this is about making sure the use is appropriate, and when it's used, that the infrastructure that sits behind it doesn't lead to leakage. One of the things which was evident was that actually some of the impacts of the usage of nitrous oxide was actually not about actually patients using it, but actually about the leakage in the system for the delivery of it.
Okay, thanks.
Thank you, Convener. So much to unpick here. Like Emma Harper, I'm really enjoying this conversation. I think we're just starting to get to the nub of it as we get to the end of it. Gillian Mackay brought in the subject of technology and the impact of technology. And in Scotland, we're way behind the curve in terms of what technology can deliver. And I don't think we've quite recognised what it can deliver in terms of climate change and delivery of that against that agenda. Because one of the things you talked about there was over-prescribing or wrong prescribing. So I'm going to go back to this idea of 14 health boards and our ability to adopt and apply technology to its best effect. Where are we in terms of that? How do we overcome that inertia that seems to be a major drag on how the health service moves forward in this agenda?
Okay, so can I be clear about what we're talking about here then in terms of technology? Are we talking about machines and systems that support care? Are we talking about the data that sits behind that for planning care? Because all
of it's interlinked, to be fair. But I think we've got data coming out of our ears in Scotland, but really no way to interrogate that. And I think that would be a starting point in terms of some universality of how we collect data and how we interrogate that data and apply it in a real time workplace.
And I'm glad you've said that, because I think the data is key. Data for me is the key starting point in all of this, and making sure that we've got systems and approaches in Scotland that support the use of data across the country to guide how we provide care, and also to give us an assessment of the quality of care that is provided is the absolutely critical starting point. So the way that our national organisations, such as Public Health Scotland, such as at the moment NSS and NES, hold data and use that data becomes really important. That's at that national level. Public Health Scotland in particular, the analysis of that data, we see them in the reports that they produce on a regular basis that give us that assessment of care. Also allows us and informs us to then do data modelling, which informs research reports such as the Scottish Burden of Disease, and gives us a sense of not only where we are just now, but actually what's coming in the future as well. So that use of data is absolutely critical to a precision public health approach to the way that we provide or improve the health of the population for the future. I think data is king. I think that we have still a bit to go in terms of being comfortable with where we are using data in this country. I would like to see much more availability of data from general practice in particular, but from community care, and how that's fed into our overall system and supports our system and understanding of how that system is functioning, and also has the opportunity for it to be used appropriately to inform research as well. So data is the starting point. Now, I think, in my view, the approach to planning, which you'll all be aware of now in these subnational planning groups, gives us the opportunity in a way that perhaps hasn't been there before, to make sure that rather than having those 14 different flavours of technology adoption across the country, the subnational planning groups that have been set up allows us the opportunity to make sure that that is performed much more consistently across the country. And whether that be adoption of particular strategies, adoption of particular technologies, or just making sure that they are used in the appropriate way at a local level, that's for me is one of the key things that those subnational planning groups can eventually help us and assist us with in the future.
Just finally on that, then, would you accept then that this 14 different health boards, I'm not against there being 14 different health boards, but I think that lack of universality of basic IT infrastructure that should apply across the whole of the 14 NHS boards is a drag on our ability to deliver on this agenda.
I suppose from my perspective as a simple clinician, what I want to see is consistency across the country in everything that we do, so in the governance in particular. So whether that be in the protocols that we use for providing care, whether that be the protocols that underpin the quality assurance of our lab services, of the systems that are used within those, consistency is important. We've got a very fluid workforce. They move around the country. And I think it's reasonable to expect that as they move around, they've got familiarity with the systems that they are using wherever they are, and that they don't have to move away from that. So I think adoption and consistent adoption across the country in our patient management systems, in our point of care testing, in all of these systems that underpin the way that we provide care across Scotland is a beneficial thing, and it's something that I've always wanted to see.
So, as part of our sustainability programme, data is very important, central, and we have a work stream dedicated to that. I appreciate much the discussion has been about clinical data systems, but that work stream is looking at the systems for energy management, waste data, but also we have some very, actually I think very exciting projects that are combining data from suppliers about products with NHS data and how those products are used, and that is going to be used to help with the planning of circular economy initiatives. That particular project's been taken forward with an Edinburgh-based company as a CivTech digital innovation project. So I think you're absolutely right in that data is very important. It's essential to this agenda. We are trying to take a data-led approach wherever possible, and we do have a number of projects that are looking to join up data systems across the NHS, but also to join up data systems with the supply chain. My colleague Wendy would be able to speak more about that particular CivTech project if that's of interest.
As I say, the CivTech project is really quite interesting because it is enabling suppliers to provide us with information, maintaining their commercial security, but it also will provide in under, I think it's 4 minutes they claim, but we'll say 5, a full life cycle assessment. So that would give us a carbon footprint for those products. So that is a work in progress at the moment, but building on that, it's also worth noting that we've just secured €7.2 million of EU Horizon funding on a data programme which is looking at supporting the remanufacturing and reprocessing of medical devices on a pan-European level. and Scotland has received €1.7 million of that directly.
So much to get into, but I'll leave you then, leave convener.
Thank you very much, Mr Whittle, for doing that. Can I thank the panel of witnesses for their evidence this morning? Before I briefly suspend the meeting, I'd just like to formally acknowledge the passing of the former Cabinet Secretary for Health, Jane Freeman, at the weekend. She was a dear friend and colleague to many of us sitting around the table this morning, and pass on mine and the committee's condolences to Susan and her wider family and those who loved her. And I'll now suspend the meeting. The next item is an evidence session with the Cabinet Secretary for Health and Social Care and supporting officials on the Medical Training Prioritisation Bill Legislative Consent Memorandum LCM S6 72, which was introduced in the Scottish Parliament by the Cabinet Secretary for Health and Social Care on the 21st of January 2026. The legislative consent process set out in Chapter 9B of Standing Orders requires the Scottish Government to notify the Parliament by means of a legislative consent memorandum whenever a UK Parliament bill includes provision on devolved matters. Each LCM is referred to a lead committee to scrutinise the LCM and report on it before the Parliament decides whether to give its consent to the UK Parliament legislating in the manner proposed. The Medical Training Prioritisation Bill was introduced in the House of Commons on the 13th of January 2026. The purpose of the bill is to introduce a system that gives graduates from UK medical schools and certain other groups priority for training places to become doctors. The bill has been introduced as emergency legislation subject to an expedited timescale to allow prioritisation to be implemented for training programme recruitment rounds that are currently live and would affect those receiving offers for training posts starting in August 2026. I welcome to the committee Neil Gray, Cabinet Secretary for Health and Social Care, Lucy Gibbons, Head of Health Skills Development and Delivery Unit, and Lucy McMichael, Head of Branch Social Care Legal Services Unit, Scottish Government. And I invite the Cabinet Secretary to make a brief opening statement.
Convener, colleagues, thank you for inviting me to speak with you today. The committee will be aware that the bill passed through the House of Commons unamended on the 27th of January across the UK and here in Scotland. The dedication of our NHS staff continues to be remarkable, but we must be honest about the challenges facing our medical workforce, and I want to thank those doctors who took part in Phase 1 of the Future Medical Workforce Project, who shared their views on these challenges candidly. We cannot ignore the increasing pressures within the UK medical training pipeline affecting our resident doctors. Demand for both foundation programme and specialty training posts has grown sharply. In 2025, 12,000 UK-trained doctors and 21,000 internationally trained doctors competed for 9,500 specialty training places. This bottleneck threatens the progression and retention of doctors who have trained in the UK and who are most likely to stay and build their careers here. So to match the increase in undergraduate places, this government has created 252 foundation year places since 2021 and a further 72 to be added in 2026. Furthermore, in line with anticipated future workforce needs, approximately 850 additional specialty training posts across multiple specialties since 2014. To help address concerns about training bottlenecks this year, the draft Scottish Budget provides an additional £14 million for specialty training posts. This will increase the number of available posts in 2026 by approximately 10%. While this government can take action in Scotland, the impact of this on the UK-wide pool of posts and ultimately the experience of resident doctors in Scotland is influenced by the actions of other UK governments. So it is against this backdrop that the Medical Training Prioritisation Bill is being progressed. It is right that training posts are determined by future workforce needs, but we cannot risk losing those we have trained in our world-class universities. Although Scotland experiences these pressures to a lesser extent than other parts of the UK, the reality is that we operate within a UK-wide recruitment system. The moving together on a four nations basis is the only way to ensure Scotland is not negatively impacted. If prioritisation were to apply without Scotland, we would inevitably experience displacement effects. This bill provides a lawful and proportionate mechanism to prioritise UK medical graduates alongside other priority groups where limits are required. It also ensures that from 2027 onwards, we can recognise and value internationally trained doctors who have made significant contributions within the NHS by enabling them to be prioritised through future regulations. The concurrent regulation making powers with safeguards around Scottish Ministers' consent provide the necessary assurances that our devolved responsibilities are fully respected. I also want to stress that this bill will not prevent international recruitment. Indeed, international students will always be welcome in Scotland for the positive contribution they make to our campuses, to our economy, our NHS and our local communities. What this bill will do is support a sustainable and reliable future supply of doctors and ensure that those who have trained here have the opportunity to progress their careers. So on that basis, Convener, and having considered the legal, financial and operational implications, the Scottish Government recommends that the Scottish Parliament grants legislative consent to the bill.
Thank you very much, Cabinet Secretary. We now move to questions, and Sandesh Gohani.
Thank you. And a declaration of interest as a practising NHS GP. Good morning, Cabinet Secretary. On the 14th of June 2025, at the Scottish Conservative Conference, I announced pretty much this policy as one of our policies that we would want to come in. And so obviously I would support a bill like this. Given it has come through so quickly, unamended through the House of Commons, do you feel that we should be spending a little bit more time looking at it and taking evidence from, say, IMGs?
Thank you, Convener. I thank Dr Gilhani for his question. I recognise the expedited timetable, particularly in the House of Commons, and that is, as the Convener has set out, in order to meet this year's recruitment rounds. We have, as a government, been discussing these matters with this government at a UK level for quite some time, and we believe that this is, as I said in my opening statement, the most proportionate legal suggestion to have come from them that we believe is also workable, and that is the critical element. So it's clearly for the committee to determine its work programme. I could not direct that, but I believe that this bill is the right thing, the right course of action to take. It's balanced, and that's why we're recommending the Parliament give its legislative consent.
Again, it's a bill that I very much support and thought was key. You look at countries like Australia, their graduates all get the training places that they want, and then what's left over is what people who come from, say, this country that are going and emigrating over there get to experience to start with. And I know we've got questions about harder to fill recruitment, so I won't touch on to that. Does this include dentists?
It does not include dentists, no.
Okay. And obviously with the specialty training programmes, GP is certainly a specialty training programme, so will this include GP training?
Yes, it does include GPs.
Okay. And when we're looking at the way that the bill is constructed, do you feel that we are going to be getting here in Scotland a number of people from, say, England wanting to come up here to practice?
I think that opportunity will remain and potentially be an expanded opportunity because of the prioritisation that is going to be made on a four nations basis. So there is going to be a reduced competition for UK-based medical graduates, and it's going to be proportionately harder for international medical graduates. I reiterate, though, that international medical graduates, for the issues that you're talking about there around those harder to fill places in particular, are still going to be required, still going to be needed and very much valued by this government. And previous iterations of this policy in our discussions with the UK government we were not comfortable with because we felt would impinge on that ability to still be able to recruit internationally. I want to leave with no doubt the committee as the government's position that we're going to still require international medical graduates, and that is going to still be the case going forward even under this policy.
And if a international student were to come and study, say, in Glasgow University, I think it's very important that we state that they would be given the prioritisation that anyone from this country that went to Glasgow University would get within the system. Is that correct?
That is correct. Anyone that has started their medical education through a UK university will be able to be treated as being a UK domiciled graduate. And that is where the difference lies. So from a foundation year perspective, anyone that's carried out their foundation programme here in the UK will be prioritised as a UK medical graduate. Those that are entering for the first time in the specialty position, that's where the prioritisation will start.
And my final question is, if you are a graduate, say, of a Scottish university or a graduate of a Welsh university, again in England, given it's a UK-wide recruitment, you are giving prioritisation over others from international, but you'd be ranked within. So if you went to Scottish University and you chose to go to England for special training, you wouldn't be below somebody who went to an English university or vice versa.
That is correct.
Thank you.
Emma Harper.
Can I ask if this affects ScotGem allocation as part of their foundation year 1 and 2? Is this because I'm interested in how successful ScotGem has been in NHS Dumfries and Galloway for recruiting doctors for rural practice. So does this affect ScotGem students?
Thank you, Convener. I recognise Emma Harper's long-standing interest and advocacy for ScotGem, so I understand her concern to make sure that this is not impacted. ScotGem is not impacted by this process, no.
Okay, thanks.
Fine, Whittle.
Thank you, Convener. Good morning, Cabinet Secretary. I think we're all in agreement the impact, the positive impact that international students have, or international graduates have, and international GPs and medical staff have in our NHS. I think what concerns me with this legislation is we have a cap on medical graduates currently in effect in Scotland in terms of home-based graduates. Will this necessitate a move of that cap or raising of that cap to allow more domiciled Scottish students, graduates, into a training place? Will that change that whole perspective?
Is that in terms of specialty training places?
Yes.
Mr. Whittle could clarify. So we've thank you, Mr. Whittle. I thank the convener. As I said in my opening statement, we've provided additional specialty training places, recognising that it is a competitive landscape. And I put on record, I think it's right that it's competitive. I think that it serves to ensure that we are getting the best coming through. Scotland, the rest of the UK, are in terms of medical education and training, are held in very high esteem internationally. And so as a result, we ensure that we've got incredibly high standards, and those that come through are the best coming into our system. We keep under review the number of specialty training places on an annual basis. We've allocated, as I said in my opening remarks, an additional £14 million to increase specialty training places by 10%. That matches proportionately what has been delivered by the UK government as well. Obviously, we will keep under review the impact that this bill will have in terms of the competition and the delivery of our workforce supply that's going to be required, and whether we need to move that up or down in future years.
Thank you. And just to follow up on that, you say that increasing the number of specialty training posts in Scotland. How are you ensuring that that increase is reflective of the demand that will be now that this bill has been placed?
Well, that's part of what is discussed on a Four Nations basis in terms of recruitment. We, through NHS Education for Scotland, there are representatives in these discussions. They help us to determine what our specialty need is going to be and how many people are to be recruited to that. As I say, it's a fine judgment to be made around the level that is to be brought forward to ensure that it's competitive, but also to ensure that it delivers the number of specialty places that would allow us to fill the gaps in our supply that we need to fill.
Just finally, the competitive nature of this, totally understanding that's the right thing to do. I think if I'm being completely selfish, we want that competitive nature for people to choose to be here. So how are we ensuring across the four nations that Scotland sits at the forefront of that and make sure that the access to that in these specialty training is of a size that makes it easy for people to make the choice to stay here?
There are a number of factors that are going to determine, Convener, the attractiveness of Scotland or indeed any other part of the UK for people to live and work. I think there are a number of reasons why people should want to choose to live in Scotland, but also to work in the NHS in Scotland that I'm more than happy to put on the record. But we're also looking through NES to make sure that we are setting out a competitive and supportive not just education programme, but a specialty programme as well. And I do believe that I've certainly not had any feedback in discussions with either the BMA Resident Doctor Committee or indeed from the Students' Committee that is to the contrary. There is concern there from the BMA, which is why they've set out their some places qualified support, but support for this bill as making it easier for their domiciled medical graduates to UK domiciled medical graduates to be able to access specialty places. And that's part of the reason everybody is aware of the particular issues that there are between the BMA and the UK government at the moment. This bill is to try to resolve some of those issues.
Thank you.
David Torrance.
Thank you, Convener. Good morning, Cabinet Secretary. What impact could the bill have on the vacancy gaps in areas such as rural Scotland where places are hard to fill?
So we're taking forward a number of measures in order to try to improve recruitment to rural and island areas. We've already spoken, Emma Harper has raised ScotGem as being an example. We have taken forward a number of different programmes in order to provide the rural and island communities with the people to serve those services in those areas. I don't think this bill will necessarily directly change the perspectives in that regard, but when this bill is taken alongside some of those programmes, then I think it has the potential to help us to meet those skills, needs, gaps in our rural and island communities.
Thank you, Cabinet Secretary. What evaluation has been undertaken of the impact of the bill may have on specialist programmes and have historically had higher levels of non-UK graduates, such as general practice and psychiatry?
So this relates back partly to Dr Culhaney's questioning, where there will still be a need for international medical graduates for some elements of specialty where there isn't the same popularity amongst UK domiciled medical graduates. So that will not change. I expect we will still have, and the dynamic that may change is that the more popular specialty places may amongst UK domiciled students may be harder for international medical graduates to come into. But if they continue to have a determination, as I hope they do, to come in, live and work in my case, and I want that to be in Scotland, but in other parts of the UK, then they may have to choose other specialties in order to come and practice.
Thank you. The third question.
Emma Harper.
Thanks, Convener. We talked about ScotGem earlier, but also specialty training means that a GP could spend part-time in a GP practice or part-time as a diabetes specialist or some rheumatoid specialist or something like that. Does this enable, the continuation of supporting rural practice in that, doctors can split their time between in-hospital specialty following training or GP practice as well?
I thank Ms Harper for a question. I'll bring Ms Gibbons in a second around the dynamic at play here and what impact this bill will have in terms of that ability to have a mixture of practice and looking to diversify. I think in areas such as rural communities where Ms Harper's from, where I'm originally from, the need for us to have medical professionals who have a diversity in their practice is incredibly important. We understand the need for rural practitioners, whether they be medical or wide from the wider multidisciplinary team, need to be able to have a diversity in their portfolio. They need to be able to deliver a wider variety of service, and I have seen that in evidence in the various visits that I have done in rural and island communities, where you are seeing people stepping into areas of specialism that in the Central Belt you would have a specialist delivering because of the capacity that's needed to be responded to. So the crux of the point that you're making is an important one for us to consider, and I'll bring in Ms Gibbons as to what the dynamic will be in terms of this bill.
Yeah, it won't affect the kind of curriculum or the way in which people are undertaking their specialty training, either in GP or in any specialty. So that will remain the same. It's just the eligibility to get prioritised at that initial point of application.
Okay. Carol Mochan.
Thank you, convener. Good morning. I'm interested in the sort of international medical graduates themselves and just how we're, going to manage. And you did, you outlined that in your opening speech. So thanks very much. But just to follow up, I just wondered if we know how many locum appointments for training, I think they call them LAT, L-A-T, and clinical fellow posts in Scotland are currently filled by international medical graduates. And has there been consideration for that group when you've been looking at how you implement the legislation?
Convener, I think I'll need to write to the committee to give numbers, but I understand the point that Ms Mochan is making around the wider impact that our international medical graduates play across the whole system, hence the importance that I place upon us being a welcoming nation to not just international medical graduates, but international workers into our health and social care system in general. And Ms Mochan and I have corresponded on this on a number of occasions. So I'll write back to the committee in terms of the numbers that Ms Mochan is asking for, because I don't have them to hand.
No, that's absolutely fine. Thanks very much for that, Cabinet Secretary. And really, my next points, I think you have addressed, but again, like you, I know we both think about this, but just making sure that it continues to be an inclusive workplace for any of our international students, and that we know that we do value them, and that the bill continues to mean that we're quite fair and consistent in our approach. I don't know if there's anything else you want to add, but I know you added that in your opening statement as well.
I very much share that concern that Ms Mochan puts on the record, which is why we as a government are content with this approach as opposed to others that had been discussed with us by the UK government before this legislation was mooted. That, in my view, would have put that position of the inclusive and welcoming nature that we want to see being brought forward, and also the legal and workable element in my opening remarks being achieved. Previous iterations of how to address this issue by the UK government didn't pass that test from our perspective in the private discussions that we had, but we're now in a much better place with this bill.
That's great. I've just got one last wee question, because I know a couple of people have had it raised. It's about Ukrainian doctors, and how have we got Ukrainian doctors working here, and is it easy enough for them to be part of the system?
So Ms Mochan will recognise that my ministerial background in this regard and my determination to do all that we can in order to ensure that we're supporting displaced Ukrainians, in this case in the health and social care system, but also for displaced Ukrainians who bring with them skills and qualifications that are much in demand across the entirety of the public sector and the wider economy. Discussions continue to be had around the sharing of qualifications and qualification standards, and I'll need to provide a written update to Ms Mochan as to the status of that. Some of that is because it's to do with regulation, are out with our control here in Scotland. But in principle, I will say now what I have said for 4 years, that we very much expect our Ukrainians who are here and have been displaced to be able to work to their qualification, because we need their skills and experience, and we can offer them an opportunity to rebuild their lives here in Scotland. So it's something I care deeply about, but I'll make sure I provide a more formal update to the committee as to the progress of those discussions.
That's perfect. Thank you very much. Thank you, Convener.
Thank you. Ms Mochan. Gillian Mackay.
Thanks, Convener. Most of what I wanted to cover has been done so by other committee members. Others have mentioned the concerns around international medical graduates and their specialties being needed, and that they'll go into specialties that aren't usually preferred by UK graduates, and that's a concern. And the potential limitations for career development has been raised as a concern by the British Association of Physicians of Indian Origin. So what equality monitoring is the government planning to undertake to detect any adverse consequences that the bill may have for international medical graduates working in the NHS in Scotland?
That is carried out on a routine basis as part of our discussions at a Four Nations level on the recruitment that's required. Seeing as I'm going to be writing to committee in response to Ms Mochan anyway, I'll happily add a paragraph as to the assurances that Ms Mackay is looking for as well, Convener.
And beyond the legislation, what can be done to make sure that graduates do feel that they are welcome here in an international space? There has been a lot of rhetoric across the UK recently. This is very anti-migrant. This could be seen as adding to not wanting people to come in and work in this country. I appreciate from what the Cabinet Secretary said that is very much not the space the Scottish Government is in. But in those sort of softer measures, what can the Scottish Government do to make sure that medical graduates are very aware that they are still welcome and that this is not to put them off coming to Scotland?
The first thing was to ensure that, because I very much recognise Ms Mackay's concern, the first thing to do was to make sure that a proposal was coming forward that was going to be workable, legal, and wasn't going to detriment or provide an unfair detriment to our international medical graduates. That was point one, and that was a point that we fiercely guarded. And to be fair, other devolved governments were in a very similar position as to wanting to ensure that that basic principle was adhered to. The second is about the culture and rhetoric that we have here in Scotland. I think we've heard today from committee a very welcome consensus as to the need for us to recruit internationally and the value that we place in our international medical graduates. I think that it's to our credit that we're in a position to be able to do so on a cross-party basis in committee today. I hope that can extend out to the wider body politic and that our political discourse can return to one of greater dignity towards our migrant workers here in Scotland than what we have seen, as Ms Mackay references, of late.
That's great. Thanks, Convener.
So there's a number of clauses in the bill that confer powers to UK ministers and which might be exercised within a devolved competence. So can you, Cabinet Secretary, expand on how the regulation-making powers set out in the bill were decided? And to what extent do you consider that this approach respects the devolution settlement?
I'll bring, again, Ms Gibbons in a second to provide a bit more detail. We've been able to secure in negotiation a number of conditions that ensure that the devolved settlement is respected, including Scottish ministerial consent. We recognise that for all the reasons that I set out in my opening statement, that operating on a Four Nations basis here is advantageous to us. We avoid unintended consequences and detriment to the Scottish system by doing so. But I'll ask Ms Gibbons to provide any further additional information that there may be in terms of how that was achieved.
Yeah, happy to do so. And you might want to refer back to the letter that Mr Gray has recently sent to the Delegated Powers Committee. That details the kind of four powers that are in the bill, 3 which are treated the same. So that is that consent element that Mr Gray's referred to. But also there's an option there for that to be a concurrent power. So Scottish ministers could exercise that power by themselves if they wish. And then the final one is slightly different, and that's to reflect the international trade obligations of the UK government, and whereas in certain circumstances that that's reserve power, so that wouldn't require our involvement.
Can I thank you, Cabinet Secretary, and your officials for your attendance today. You are free to leave, and we will move on to our next item on the agenda, which is the 4th item on our agenda. It's to consider 2 public petitions previously referred to this committee. These are PE 1924, complete an emergency in-depth review of women's health services in Caithness and Sutherland, and PE 2156, improve access to ADHD diagnosis and treatment across Scotland. The Citizens Participation and Public Petitions Committee referred petition PE 1924 to this committee on the 15th of June 2022 in the context of the committee's wider consideration of health inequalities. And they referred petition PE 2156 to this committee on the 18th of June 2025. Following its referral, this committee agreed to consider that petition as part of its inquiry into ADHD and autism pathways and support. The committee completed that inquiry by publishing a report on the 2nd of February 2026. So if I take each of these petitions in turn, with regards to PE 1924, could members advise how they would wish to proceed?
Convener, I think that this petition is of considerable importance, and I think we should consider. We don't have time to go into it in the depth that it requires, and I think it should be carried on to the next session.
Gillian Mackay.
Thanks, Convener. I think it should be. I think this one in particular should be left open with something put into our legacy planning document about how the next committee could take this forward. I don't think it's an issue that has concluded yet, and something that a new iteration of this committee should definitely look at.
Sandesh Gohani.
Thank you, Declaration of Interest, practising NHS GP. I do feel that we should be keeping this petition open. It's certainly one that I don't think we have time to do justice to and look at. And I do agree with Gillian Mackay that we should be putting this into our legacy report. But my feeling is we should maybe ask for it to be more than just in Caithness and Sutherland.
Emma Harper.
Thank you, Convener. In my work, I've been involved quite heavily with the Galloway Community Hospital Action Group, looking at maternity services in the southwest of Scotland, which linked with a previous petition about Caithness and maternity services. And I know that there's a Scottish Maternity and Neonatal Task Force that's been created to look at maternity issues overall. So I would be happy to keep this petition open. Yes, mention it in the legacy report, because there's obviously ongoing work looking at maternity, and especially for rural areas as well. So I think I'd like to keep this open.
Okay. Carol Mochan.
Thank you, Convener. It was just to agree. I think members have made good points about the fact that there is ongoing work to be in this area, and in the legacy report, I think would be really important for the next committee to be aware of this petition and its continuation. So I would agree. Thank you.
Thank you. I think committee's in agreeance then, okay, of how we wish to proceed with PE 1924. With regards to PE 2156, members wish to make comments about that petition and whether to keep that petition open. Gillian Mackay.
Thanks, Convener. The committee's obviously concluded a large piece of work on this topic in particular. I'd be content to close this one, but I do think there's, given the work that's going on in this area, I think again for our legacy report, there's the potential to highlight to any new committee that this may be something a couple of years into the next Parliament that should be looked at to have a look at any improvements and any more work that's needing done in this area.
Emma Harper.
Thanks, Convener. So I agree with Gillian Mackay. I think we've done a substantial bit of work, but I think we need to keep an eye on progress because of the significant delays in assessment and diagnosis that we uncovered in our report.
Yep. Brian Whittle.
Yeah, I think this is a topic that will be discussed on going forward into the next Parliament. But as I say, we've fortunately done a significant amount of work on this and the report. So I think closing this particular petition is the right way forward. But we know that this will be raised again in the next Parliament.
Elena Whittam.
Convener, and I agree with my fellow colleagues. I think that we have done the petitioner's request about looking into this in depth. I do think that given what is contained in the petition about the lack of a diagnosis and what consequences that has on somebody's life, I think that this is something that the next committee should have an ongoing look at. But I think that we have fulfilled the requests of the petitioner.
Okay, so it sounds like we're in agreement then to close the petition with the committee's work in this area mentioned in our legacy report. At our next meeting, we will undertake periodic scrutiny of the work of Food Standards Scotland and the now finalised National Good Food Nation Plan, and that concludes the public part of our meeting today.